Hi, good morning and greetings. Palamia, so much. Thank you for joining us today. Today's very special for me personally because I get to introduce my brother, Dr. Don WARNE. And just from a personal introduction side of things, my brother and I grew up as advocates for our father. Before, well, my brother may have known what the word meant, but I didn't. But we were advocates for my father who had MS and used a wheelchair before ADA, before Americans with Disabilities Act. So mom would send Don to the front door and I would go through the kitchen and Don would tell the manager of the restaurant, we're going to eat here with our father. And my brother's in the kitchen making sure there's room for his wheelchair to get through so we can eat in this restaurant. So what kind of empowerment did that give us as young people standing up for our father? And that's something that both of us kind of got into these fields, I think, addressing that life experience as young people having disability in the family. So my brother got into the health fields to address those health disparities in Indian country. And then I was geared towards the disability factors. And it's wonderful that we've had a life giving back to Indian country in the world of healthcare and health disparities. My brother has done many great things. I'm very proud of him and what he's done. And most recently is now moving over to Johns Hopkins University from University of North Dakota, where he created many programs in public health, the first ever Indigenous public health PhD program, as well as Indians in the med school that he was chair for. And now at Johns Hopkins, he will be the co-director of the new Indigenous Center for Health at the Johns Hopkins. And so it's my great pleasure to introduce my brother, Dr. Don WARNE, and I'm sure he'll share a wealth of information regarding some of the new strategies addressing disability, how it impacts us in our culture as Indigenous people. And everything he does is for Indigenous people and a better quality of life through healthcare. So again, thank you so much for joining us today. And again, my great pleasure to introduce my brother, Dr. Don WARNE. Welcome.
All right, well, thank you so much, Jimmy. It's always interesting to be formally introduced by my brother, because usually he just says, this is my bro, and that kind of leaves it at that. But it's always interesting to have a formal introduction within the family. But thank you so much, Jimmy, and really appreciate all the work that you are doing to address equity in the field of disability for American Indian and Alaska Native people, and just been very pleased and honored to be a part of our family and all the work that is being done to try to address health equity. So again, my background is both in medicine and public health, and we're very fortunate to come from a family with a lot of traditional healers and medicine people. So we've been exposed to the field of health and medicine from a number of perspectives. So I'll talk a little bit about that, but also looking at the medical and public health impact of disability on Indian country, and recognizing that there are medical and healthcare related issues, but there's also challenges related to population health and the whole arena of prevention. And as we know, with historical trauma and with the impact of colonization and all of these other factors that have an impact on Indigenous peoples, that certainly has a public health impact on rates of disability for American Indians as well. So I'm planning to discuss these items for maybe 45 or 50 minutes. I do want to leave time at the end if there's any questions or comments as well. So as was mentioned, I just recently took a new position at Johns Hopkins University. I'm the co-director for the Center for Indigenous Health. Just real briefly, this was the Center for American Indian Health for about 30 years. Started in 1991, and its focus has kind of evolved initially from infectious disease to then embracing more work around chronic disease, mental health, and maternal and child health. And now we'll be expanding our work to include international Indigenous populations as well. So today, again, we'll be focusing on the medical and public health impact of disability in Indian country. So just our learning objectives will explain the different roles of public health and medicine as it pertains to disability. And as Jimmy mentioned, we have our father who passed away more than 10 years ago. It's hard to believe it's been that long, but he was afflicted with multiple sclerosis and really had a lot of challenges related to that. And I remember as a very young boy, and my father was athletic. He was 6'4". He was strong. He played football when he was in high school, but then watched his physical body deteriorate over the years. But his mental capacity and his strength of spirit were just truly inspiring. And I was able to see the role of public health services very directly from a patient perspective, but also medical services and some of the unique aspects to consider for American Indians. And I know most of you are probably familiar with a lot of the disability disparities in American Indian populations, but we'll describe a high-level overview of some of those disparities. And then we'll look at developing solutions to improve outcomes for disabled persons in tribal communities. And we have to recognize that in public health and medicine, one size does not fit all. We have to have cultural factors integrated into how we address disability from a tribal perspective. So I'd like to start these discussions with a traditional story. In Lakota, we did not have a written language, so we don't have old textbooks or written documentation of our history and culture and belief systems, but we kept our understanding of culture and life lessons through stories. And there's a story of three sisters walking along a river. And as they are walking along the river, they see babies and young children in the water struggling to stay afloat. The first sister sees this and declares this is an emergency, it's a crisis. We need to get the babies out of the water right now. The second sister thinks about that and says, no, we need to teach the babies how to swim so they can survive while they are in the water. And the third sister keeps walking upstream, and the other two get angry with her and say, where are you going? Why aren't you helping us? And she says, I'm going to find out who's putting these babies in the water, and I'm going to stop them. And that's literally public health and literally working further upstream. And when I look at my own career and some of the work that I've done, thinking about things like type 2 diabetes and its complications like amputations and blindness and heart attacks and stroke and all of these challenges that we face with things like diabetes, we spend so much of our time and energy and resources addressing the crisis, right? We're spending a lot of money on amputations and dialysis and heart surgery. Then from that second sister's perspective, we also spend a lot of resources addressing things like medical care and blood sugar control and seeing the podiatrists and optometrists annually. But working further upstream and trying to do primary prevention, we don't do nearly enough. And when I think about primary prevention for some of the challenges that we face in Indian country, we can't just take the practices that are done in the non-Indian world and expect them to work effectively for us. And when we're going upstream in American Indian populations, it's not just upstream to early childhood. We have to think intergenerationally. And we have a long-standing issue related to historical trauma and the intergenerational impact of colonization and marginalization and loss of food systems, loss of sovereignty, and unfortunately, loss of cultural practices and loss of language. So in that traditional story, they don't use the terms primary prevention, secondary prevention, and tertiary prevention, but that's what that story is about. And we need each of those three sisters to work effectively. But I think in our current system, we don't spend nearly enough time on primary prevention and working upstream. So that's why we'll talk a little bit about the role of public health and medicine when we're dealing with disability. First, I want to acknowledge my family. As mentioned, we come from a family of traditional healers. On the upper left, that's our uncle Virgil Killstraight, who was our Sundance chief for many, many years. And I learned a lot from him about traditional ceremony and traditional practices. And he was just a tremendous traditional healer. We unfortunately lost him several years ago as well. Our elders are getting older and we're losing them. And it makes me worried about the future and in terms of making sure that we are maintaining those traditional practices. On the right, that's my uncle Rick Two Dogs. He's in his 70s and one of our very well-known medicine men still working in Pine Ridge. And also that's our cousin Maria Yellow Horse Braveheart, who's very well known in the historical trauma literature. And she's a cousin, and we've participated in ceremony together and done a lot of work around the whole idea of historical trauma. I also did want to acknowledge Arizona. I worked for a number of years in the state of Arizona, primarily with the Akimalaatam people, the Pima Indians in both Salt River and Gila River, and got to know many of the traditional healers from their healing traditions. And it's just wonderful healing traditions. And it's a picture here of Royce Manuel from Salt River, Pima Maricopa Indian community, was a wonderful friend and colleague for many, many years. And unfortunately, he passed on to make his journey to the spirit world as well just last year. But he was a wonderful knowledge keeper and keeper of traditions and ceremony for the O'odham people. And just want to acknowledge the beauty of the cultures in Arizona that I was really fortunate to be a part of. We're also very fortunate. We have photographs of a couple of our great-great-grandfathers. This is Chief Stabber, and this picture was taken in 1872. And he was one of the Lakota and Dakota chiefs who visited Washington, D.C. when they were doing land settlements for the reservations. And I love this image. This is taken in Washington, D.C., and I think about how much courage it had to take to essentially go to a foreign land and ride on a train for the first time to go to Washington, D.C., and to depend on interpreters to communicate and try to advocate for our people. And I feel like that sense of leadership and advocacy for our people really is deep rooted in our family. And this is a Chief Stabber from my great-great-grandfather. This is Kills on Horseback, and he was another great-great-grandfather from that same time frame. And in my mom's family, he was very well known as a traditional healer and leader of cultural ceremonies. And again, just so fortunate to both come from traditional families that are well connected to culture and ceremony. But I feel so blessed that I actually have these pictures of two of our great-great-grandfathers. So for that family history and where I'm from, Stabber's son was Crandall Stabber. Crandall's son was Louis Stabber. And Kills on Horseback, one of his daughters was Eliza. She married Bissonette. They had a daughter named Eva Bissonette, and Louis and Eva then were married and had my mother, Beverly Stabber. So that's kind of our family history on my mom's side. And my mom is 83, still working as a nurse. We like to tease her that she failed retirement. She tried to retire and it didn't take, so she's still working as a nurse educator in South Dakota and is a wonderful mentor and advocate for the health of our people. So I just feel so blessed to come from a family with so much deep-rooted connectivity to traditional medicine and healing. And also want to acknowledge my father, James Warren Sr. His mom was actually born in Eagle Butte, South Dakota, and his dad was first generation from England. So that's why we had the last name Warne, actually. But my dad went through all kinds of challenges when he was just finished high school. He was in a terrible car accident. You can see the truck there. He was not expected to survive the car accident. He was in the hospital in Phoenix for 200 days, actually. And they feared that he would never walk again, but he did. And he actually was able to recover from that and was very active physically. And again, he is from South Dakota originally also. He moved back to Rapid City, South Dakota in the early 1960s. And that's when my parents got married in 1962 back in Rapid City, South Dakota. So that's where my brother and I come from, and that's our roots. And just a picture from my medical school graduation in 1995 from Stanford University. It was my brother and I when we were very young and had dark hair instead of gray hair. And I just love this picture. It was actually my father's last trip outside the state of Arizona. But after he had recovered from his motor vehicle accident and he was healthy for a number of years, when he was about 35, he started getting symptoms of multiple sclerosis and had difficulty walking, was eventually pretty severely disabled due to MS. And I think that's why my brother and I do the work that we do, is that deep-rooted family and personal connectivity to both cultural medicine, but also issues related to disability. So let's go ahead and also look at the terminology that we use. We hear lots of words that are used interchangeably, like American Indian and Native American, but let's actually look at what those terms mean from a legal perspective, so we're kind of on the same page with the terminology. So legally, the race is called American Indian and Alaska Native, and that's the terminology we use in the US Census. So when we track census data regarding race and ethnicity, there's 5 races that are recognized, and actually only one ethnicity that's formally recognized by the federal government, and that is Hispanic. So you're either Hispanic or non-Hispanic. And the 5 races are white or Caucasian, Black or African American, Asian American, Pacific Islander, or American Indian and Alaska Native. And the reason it's American Indian and Alaska Native is that not all Indigenous Alaskans are American Indian. So for example, the Inuit populations in northern Alaska, they are not American Indian. They're actually more of a circumpolar population. So there are Inuit peoples in Alaska, but also in Siberia, Canada, and Greenland. So if you call an Inuit person American Indian, they'll get angry with you because they are not American Indian culturally, but they are indigenous to North America as well as Alaska. The Athabascan groups in Central Alaska are culturally American Indian, and actually there's Athabascans across North America, including Alaska, Canada, the coast of California, and actually Navajo and Apache tribes are Athabascan cultural groups as well. So that's why it's called American Indian and Alaska Native. There's another subpopulation, which is enrolled tribal members. So when we're talking about census data that's self-identified American Indian and Alaska Native, and in truth, when you're filling out the census, you can check any box that you want to, right? But an enrolled tribal member is actually a political designation. And typically to be eligible for Indian Health Service, you typically have to be an enrolled tribal member or a descendant with close ties to the community. So an enrolled tribal member is not a racial designation, it's a political designation, much like the resident of a state. So when we're looking at census data, we have to be cognizant of the fact that that's different than IHS or tribal enrollment data. So when we're looking at the data and trying to understand disabilities, we have to recognize that Indian Health Service does not represent all American Indians and Alaska Natives. In the 2020 census, there were about 9.7 million self-identified American Indians and Alaska Natives, so 9.7 million. Of that number, about 2.4 million use the Indian Health Service. So the majority of American Indians and Alaska Natives are not in the IHS data set. So it's something to keep in mind, because we quite often use IHS data as a proxy for all American Indians, but it's not. We have to be cognizant of that. For example, I live in Grand Forks, North Dakota. There are no IHS facilities here, and the closest one would be an hour-and-a-half drive away. And I have insurance, so I can go to the private sector. So if you are not an active user of IHS within the last 3 years, you're no longer in that database. I'm not an active user of IHS, so I'm American Indian, but I'm not in the IHS database. So just something to keep in mind. Again, we also use the term American Indian and Native American kind of interchangeably. So Native American is actually legally defined. In 1978, there was the Native American Programs Act, and Native Americans are legally defined as American Indians and Alaska Natives, but also Native Hawaiians and indigenous peoples of the US Pacific Islands. So American Samoans are legally Native Americans. The Chamorro indigenous peoples of Guam are Native Americans. So if we're being inclusive of all indigenous US citizens, Native American is appropriate. But if we're talking about tribes or American Indians, Native American is actually not the right term. And I've heard a lot of people arguing about that because they prefer the term Native American, because the reason we're called American Indians is that Columbus thought he was in India. So because Columbus was lost at sea, I'm now an Indian. You know, there's an Indian Health Service and a Bureau of Indian Affairs because Columbus thought he was in India. So a lot of people don't like that term, which is understandable. But we also have to remember that American is actually named after another Italian explorer, Amerigo Vespucci, right? So when we're thinking about which is the better term, American Indian or Native American, in many ways we're arguing over which Italian do we want to pay homage to, Columbus or Vespucci, right? So what the term that I prefer is Indigenous, and it's much more inclusive and encompassing. So the Indigenous peoples are the original inhabitants of each part of the globe. So that includes in the US, American Indians and Alaska Natives in North America, as well as Indigenous peoples to other states and territories that are not in North America, including Hawaii, Samoa, and Guam. So that's the reason why we now use the term Indigenous more frequently, because it is more inclusive of a term. When we look at the Indigenous peoples of North America, again, there's Athabascans throughout North America. And of course, where Jimmy and I are from is the Great Plains in what is now the Dakotas. So when we think about this, we really need to understand what is the impact of colonization on the Indigenous population of the US and Canada and other parts of North America and really other parts of the world. So this map is really just looking at the 48 states in North America here and the impact of colonization. And we have to recognize that colonization started with the colonies, right? That's why it's called the colonies in the northeast of the United States and the eastern seaboard. And many of those tribes were just wiped out due to warfare and spread of disease like smallpox. So the result is the majority of American Indians and Alaska Natives live in the eastern or the western half of the United States. And there's relatively few American Indians left in the eastern half of the United States, except for some pockets of population. So when we think about colonization and loss of land and territory and language and culture and sacred sites, that has an intergenerational impact on the health of our people, including risk for things like disability. So we see a lot of disability associated with injuries. So we could have physical injuries related to high-risk behaviors in some cases. We could have physical injury related to chronic disease like diabetes, in which we see things like amputations and blindness and heart disease and stroke. But we also see mental health outcomes in terms of unresolved trauma. And we certainly see mental health related disabilities as well. So when we are that third sister walking upstream, for American Indians and Alaska Natives, we have to look further upstream that includes intergenerationally to understand the social circumstances that put some of our populations at greater risk for poor outcomes. So much of my research has been focused on types of trauma and addressing the impact of unresolved trauma on health outcomes. And I do see that there was a question regarding the slides, and yes, these slides will be made available. So I'm happy to share these slides if you are interested in that. So there's a lot of research lately looking at emotional and psychological trauma. This could be, one-time events that are traumatic. There's also ongoing relentless or toxic stress and living in poverty, dealing with social isolation. The pandemic, has caused kind of ongoing toxic stress for many people. There's also childhood trauma, which has a terrible long-term impact on health, but also even risk for things like physical injury, risk for things like diabetes and cancer, and risk for other types of causes of disability, including mental health disparities. So we have to think about adverse childhood experiences, but even beyond that. And for Indigenous communities, when we think about that deep-rooted sacred connectedness to place, again, we are the original inhabitants of this land. Loss of land is traumatic, but it's more of a spiritual trauma. And when we lose language and culture, that's also traumatic. But loss of other things like food sovereignty and food systems also creates risk for disease and subsequent risk for higher rates of disability. So when we think about this idea of trauma, if I were speaking to a group of surgeons and I said trauma, they think physical trauma, right? Physical injury, like a level 1 trauma center. Well, there is physical trauma, but there's also psychological and emotional trauma. And again, for Indigenous peoples, a whole field of spiritual trauma. So when we think about this from a holistic perspective, we have to recognize that the issue of trauma and its impact on public health and its subsequent impact on the needs for medical services just really is ubiquitous in Indigenous populations. And I would put forth that any culturally connected Indigenous person has historical trauma because of that cultural connectedness to place, that land-based healing and land-based connection to our ancestry and to our cultures. So again, in recent years, I've done much more work trying to understand the impact of historical trauma and the intergenerational basis for chronic disease disparities, including chronic issues like disability. So we have unfortunately faced challenges related to genocide. Many of our tribes, particularly in the eastern half of the US, are no longer here because of the impact of colonization and warfare and spread of disease. I'm sure many people are familiar with the history of boarding schools, and these were timeframes where we had forced boarding school participation. And the way the federal government was able to do that is that once our people were put on reservations, we lost our food systems and food sovereignty. So we became dependent on the federal government for food. So what the families were told was either give up your children to go to boarding school, or we will withhold your rations. So basically what they were telling our people is give up your children or starve. And that was federal policy. And a lot of people have a hard time believing that, but it's true. It's in the federal, it's in the documentations. And if you just even Google some of these concepts, you can find acknowledgement of that federal policy of forced boarding school participation. And the goal was really to get rid of the culture. And we saw just terrible outcomes of this. And this is not ancient history. Our mother is a survivor of boarding schools. So this is just one generation back where we saw just rampant boarding school and subsequent abuses, unfortunately. As we kind of progress through this timeline, we also have a lot of gestational stressors. So stress during pregnancy, which is bad for the mom and the baby. And then childhood stressors, things like adverse childhood experiences. And I'm sure many people are familiar with the ACE study. And when we look at the adversity that children face, the more adversity someone has in childhood, the worse their health status is as adults. There's actually a dose-response relationship between ACEs and poor health outcomes in adulthood. And then going across that timeline, of course, the adversity does not end at age 18, right? We have adulthood stressors as well. And honestly, living within poverty is very stressful. Living in circumstances where we still face racism is very stressful. Living in communities where we have very high death rates, high suicide rates, issues related to addiction, these are incredibly stressful, toxic, stressful circumstances. And also keep in mind that the children who've gone through adversity eventually become parents. And what have they learned about parenting? So we have social circumstances that are based on historical roots that put some of our populations at greater risk for intergenerational adverse childhood experiences. So very proud of my friends and colleagues at the CDC. This is actually from the National Center for Injury Prevention. And they actually have expanded the ACE pyramid. The original adverse childhood experiences pyramid has ACEs at the base. But what they've done through the National Center for Injury Prevention is recognize that generational embodiment and historical trauma put some populations, including American Indians, at greater risk for adverse childhood experiences based on those subsequent social conditions and local context. So I really appreciate their work in understanding the link between historical trauma, social conditions that put some populations at greater risk for adverse childhood experiences. And when a child is going through toxic stress, we see disruptions in neurological development, impairment of social, emotional, and cognitive development, and then adoption of health risk behaviors, early onset of disease and disability, and early death. So when we're looking at disability issues in American Indian populations, we have to be more holistic. We have to be able to look further upstream and recognize that it's not just related to early childhood, it's related to intergenerational issues and challenges. So we need to be cognizant of these things. So adverse childhood experiences are associated with all kinds of health challenges, including mental health issues, chronic disease issues, and disability. So there's a direct correlation between your ACE score, or the number of adverse childhood experiences, and risk for things like disability. So in terms of my own work in this area, I was the co-principal investigator of the South Dakota Health Survey. And it was a 7-page survey that we basically cut and pasted from other validated survey instruments, including BRFIS, the Behavioral Risk Factor Surveillance System. So we looked at self-reported health status, including chronic disease and other health issues. We did mental health screening. So not just self-reported mental health challenges, but actually screening for things like diabetes, for depression, anxiety, post-traumatic stress, and alcohol use disorder. And then we also looked at the Adverse Childhood Experiences survey as part of the South Dakota Health Survey. And we had over 8,000 respondents to this survey. And of that number, well over 500 American Indians. And I know this is a little bit of a busy slide, but in each grouping of bars, the far right is the reservation population in South Dakota. And as you can see, compared to other populations, including urban, rural, and isolated, as well as the statewide numbers, people living on the reservations had significantly worse screening for depression, anxiety, and post-traumatic stress. So for depression, we use the PHQ-2, which is a validated 2-question survey for risk for depression. We use the GAD-2, generalized anxiety disorder, had 2 questions for that as well. We used the Audit C, alcohol use disorder inventory for alcohol use disorder. So this is not just self-report, it's actually screening. And on-reservation population, unfortunately, had higher risk for things like depression, anxiety, and post-traumatic stress. In terms of outcomes for adverse childhood experiences, the ACE questionnaire outlines 10 domains of ACEs within abuse, neglect, and household dysfunction. And unfortunately, for the American Indian population, we had statistically significantly worse outcomes for each of the 10 measures. And just remarkable that all of that adversity in childhood was so concentrated in the American Indian population. So not surprisingly, since each of those 10 measures was significantly worse, the overall ACE score was also significantly worse for American Indians compared to non-American Indians. So in an ideal world, we'd have 0 adverse childhood experiences. And in the real world, in South Dakota anyway, only 17% of the American Indians had 0 ACEs, whereas 50% of the non-American Indian population had 0 ACEs. We had some American Indians who had ACE scores of 10, meaning they had experienced all of those types of adverse childhood experiences. And once you get to an ACE score of 4 or above, you are at significant risk for chronic disease, mental health issues, disability, and early death. And as you can see, we had about nearly 1/3 of the American Indian population in our sample had ACE scores of 4 or greater. So tremendous risk for things like disability and early death. And this is borne out in the data. This is data from South Dakota, a classic study that looked at average age at death, comparing the American Indian population and the white population in South Dakota. And I know it's a busy slide, but the blue bars are the American Indian deaths, and the yellow bars are for the white population. And you can see that on the x-axis, that's the age at death in years, and on the y-axis, that's the percentage of deaths during that time frame. So you can see for the American Indian population, we had 5% of the deaths were in infancy. Isn't that remarkable? The infant mortality rate is significantly worse. It was less than 1% for the white population. But you can see it's like 2 totally different populations in the same state. And the average age at death for American Indians was about 58 in this study. And this is using vital statistics data from the state of South Dakota, whereas the average age at death for the white population was closer to 80. So it's basically like 2 separate populations. So that was in South Dakota in 2000 to 2010. So we decided to repeat this study in North Dakota, and we're about to publish these data. but we decided to use the decade prior to the pandemic. You may have seen the pandemic has led to significant loss in life expectancy, particularly for American Indians, but we saw the exact same pattern. The decade prior to the pandemic, average age of death for American Indians is 58, and the average age of death for the white population in North Dakota is 79, a difference in 21 years in average age of death. I mean, these are third world health conditions that we're facing right here in the Dakotas. And not surprisingly, we also have higher rates of disability. So I won't spend too much time on this because I'm sure people are familiar with the general numbers, but elder American Indians, the population is growing, and we see that unfortunately, more than half the American Indian Alaska Native population over age 65 has a disability. Isn't that remarkable? So 1 out of 3 of American Indian Alaska Native adults with disabilities are in need of care, and many of them are younger than age 65, unfortunately. So we see earlier age of chronic disease, earlier age at the outcomes from adverse childhood experiences, and earlier age for need for disability services among American Indians and Alaska Natives. In 2020, the number of American Indian Alaska Native people 65 and older was 75% higher than it was in 2010. So what that means is that the population of elders is growing, and the need for services is growing at the same time. So it is interesting. We do have a younger population overall compared to other populations. So our population is getting older like other populations, but we're still a younger population. And we define elders differently from a cultural perspective than Centers for Medicare and Medicaid Services or the census. So just something to keep in mind when we're talking about elder American Indians, that we have different ways that we define that. And unfortunately, we face disability at a higher rate than other racial groups. So according to the CDC, American Indians and Alaska Natives are about 50% more likely to have a disability compared to the national average. And unfortunately, American Indian Alaska Native people had the highest prevalence of functional limitations compared to other populations. So when we look at these data, unfortunately, I've seen some of my colleagues who kind of blame the victims, right? And so what's wrong with that population to have such high rates of functional limitations? I think we have to be cognizant of history. We have to be cognizant of the truth of what's happened to our people. And when we look at the impacts of intergenerational trauma and adverse childhood experiences, we would expect to see these types of disparities. So what we need to do is focus on recovering from trauma and working upstream from a public health perspective. And we need to put an end to that cycle of adverse childhood experiences, and long-term that will have an impact on improving outcomes and less disability. So again, we have the highest rates of disability, but also highest rates of chronic disease, including things like diabetes and its subsequent outcomes. So because we have an aging population, high level of disability, we have tremendous need for tribally driven long-term services and supports. And we have to also recognize that long-term services and supports need to be culturally relevant. So tribal programs for LTSS really can speak to the needs of the tribal peoples or the elders and those with disabilities, but we need culturally competent care as well. So when we think about tribal long-term services and supports, and again, this is kind of where we see a blend of public health and medicine coming together through long-term services and long-term supports. We have to have care and support for the elder or the person with disability, and quite often assistance with daily living tasks. We do need medical support, but also personal and social services. So I envision these types of services really as a way to bridge medical care and public health services into very needed services for an at-risk population that is at great risk for disability and poor outcomes. So I don't need to go into too much detail here, but we need the whole gamut of health services. So again, thinking about the medical side of that equation, case management, dietary management, disease treatment and prevention. We also need hospice care. It's really just so unfortunate that in many of our populations, we don't have access to palliative care or hospice care within our tribal populations. And when we think about that deep-rooted spiritual process of passing on to the spirit world, what a shame, what a crime that we don't have adequate culturally relevant services in every population during that process of passing from the physical world to the spiritual world. We need skilled nursing, we need all the therapies, occupational therapy, physical therapy, speech therapy. We also need respite care for caregivers. I see a lot of my relatives and friends and community members who are caring for someone with a disability. Their wellness needs to be addressed as well. And we don't do nearly as good a job at that as we should. In terms of human services or other public health related services, adult daycare, but other types of things, financial management, home safety assessments, even personal care and transportation access. So across the board, when we think about long-term supports, we have to look at this from a cultural perspective, but recognize that it's an integration of healthcare and public health services. And some of the better programs I've seen it's limited. There's only a few states that have it, but CMS funds the Money Follows the Person projects, and there's a tribal initiative, and I believe there are 6 states that are funded through CMS for the MFP-TI, Money Follows the Person Tribal Initiative. And what's beautiful about that is that it's working directly with tribal nations to develop their own priorities for LTSS in their communities. Another thing to keep in mind is that this work is consistent with traditional medicine. And many of our populations had their own versions of what we might consider to be social workers in many ways. And in Lakota, we had the Shirt Wearer Society. And among the Lakota, the shirt wearers were a small group of distinguished community leaders who looked after the welfare of their people. And I look at that image and I see the one braid that's tied, and it reminds me of my great-great-grandfather Stabber. And he was looking after the welfare of his people. And when we think about this, these shirt wearers acted as counselors and high-ranking members of the leadership, because caring for the vulnerable is sacred work. The work that each of you do is sacred and meaningful work, because people who are vulnerable and have challenges advocating for themselves need us to be in those roles. So when we think about Indigenous perspectives on disability, obviously we think about physical disability, but there's an impact emotionally, spiritually, and mentally when we have physical challenges. And those cultural-based supports and even the cultural traditions like the shirt wearer societies, we can address these things in a much more holistic manner. And we cannot take that one-size-fits-all approach to addressing health challenges. We need to recognize that each population is different, and we should look at the local cultures as a source of strength and resilience. And we can address our needs from a much more holistic perspective if we do this effectively. Just very briefly, think about healing from trauma. There's a lot of work that's been done with counseling and recognizing the need for social connectedness, but also cognitive behavioral therapy. There's versions of that's actually culturally relevant and consistent with our traditional medicines. Physical activity, as much as possible, is important, even for those who have physical disabilities. Still having some form of movement as possible is so needed. And then from a cultural perspective, prayer and reconnection is just so vitally important to this whole idea of holistic healing. And we can't expect CMS to solve this for us, right? We have to do this from tribally driven and community driven, culturally relevant perspectives. And I really believe we can make a much more meaningful approach to recovery from trauma and disability if we do that. So in terms of a path forward, we do need expanded tribal LTSS and home and community-based services. Again, I think the MFP-TI, the Money Follows a Person Tribal Initiative, is a good case example of doing that. We need cultural awareness and cultural safety training, because we don't have the workforce in our tribal communities to address all of our needs. So we need champions and advocates and allies from the non-Indian world to work with us. But this has to be done from a culturally informed perspective. We also need expanded trauma-informed care. I think we're doing a pretty good job with trauma-informed care in many aspects of medical care, but we need trauma-informed public health, trauma-informed social services, trauma-informed disability services across the board. We need to be cognizant of the impact of intergenerational trauma and childhood trauma on our disabilities. Improvements in community engagement, integrating traditional medicine and cultural perspectives. And we really need to integrate behavioral therapy and medical care. It's starting to happen in some sectors, but I still see quite often we have separate silos of medical care and behavioral health services. We need to integrate those things, but also do that through a culturally competent lens. So moving forward, we need more workforce development. We need more adverse childhood experiences prevention. And in truth, if we're doing home visiting and doing things like case management for high-risk pregnancies, in the long run, that is disability prevention for that next generation. So we have to think long-term. We have to think about intergenerational impacts of the work that we can do today. All right, I think I'll go ahead and end it there. That's my email address, dwarn1@jh.edu, brand new email, just started at Johns Hopkins last month, but I'll go ahead and pause there. And I think I've left about 10 minutes or so if there's any questions or comments.
Thank you so much, Don. We really appreciate that. And if someone could identify some of the questions in the chat area, I do see one here, the last one from Kurt. As a white person, what can't I do or pay attention to on a personal day-to-day basis to promote healing for historical trauma? I think many of our non-Indian allies really want to have some tools on how they can address this. Any ideas, Don?
Yeah, well, first, just to be aware of it and cognizant of it. I think that so many of our professionals and people in the workforce are just not cognizant of the history or the terminology. So I think just as a starting point, learning some of these things is so important. And even knowing the terminology and the impact of colonization. So just being aware is a wonderful first step. And then in the day-to-day work, being cognizant among our clients that many of our people are dealing with unresolved trauma, and that's going to have an impact on health-related behavior. Even after someone is disabled, we can see an impact on health-related behavior if we have a lot of unresolved trauma. So I think that we need to be cognizant that there are unique factors in Indigenous populations related to colonization and marginalization that have an intergenerational and long-term impact on health-related behavior. And I've seen, unfortunately, particularly in medicine, among my physician colleagues, more of a judgmental approach. And we can't have that. We need to meet people where they are and understand them better and have that empathy and compassion. We need to be that shirt wearer society that's really looking out for the welfare of the most vulnerable people. So being aware of these things is such a vital first step. So I really appreciate that question, Kurt.
Thank you so much. And I believe there was another one regarding Medicaid health plan. I know that third-party billing with 638 is huge right now, but what can you do regarding the question from Jody, and how can I approach the local tribes and get some success working with them because they've had challenges reaching those tribes?
Yeah, and there's some really good examples of tribally driven long-term care services, long-term support services, and also home and community-based services. And again, I think the MFP-TI, you could just Google that, Money Follows the Person Tribal Initiative, and the states that are running those programs are really developing some innovative processes. And just for those who might not be aware, tribes have the ability to take over the management of their healthcare systems from the Indian Health Service. So that's the Public Law 93-638, in which the tribes can take over the management and actually have tribally run programs. And the Medicaid reimbursements are really good, actually. So tribes who choose to do this could develop, if they wanted to, their own LTSS programs. They could develop their own home and community-based services. They could develop their own durable medical equipment companies if they choose to. And there are a few examples nationally where this is being done effectively. But I think looking at the MFP programs is a good starting point. Historically, some of the programs that would integrate Medicaid and Medicare and tribal programs we see some good examples of that as well. So CMS also tracks these data. So on the CMS website, they have a whole American Indian Alaska Native page, and you can identify some case examples where this is being done effectively.
I like that. Follow the money. It's a great model because obviously that wherever the money ends up is where the answer is. And if you could something that I learned from you, Don, is in my lectures, I often say, as a Native person, in order to double our health care, we can commit a federal crime and end up going to prison, and suddenly our health care is doubled. Can you address some of those comparatives between Medicare, Medicaid, veterans, prisons, and IHS funding levels?
Yeah, unfortunately, Indian Health Service has been terribly underfunded for decades. And for example, if we look at the per capita expenditure for Medicare, that's about $12,000 per person per year. Medicaid is over $8,000 per person per year. But when we look at Indian Health Service, it's closer to $4,000 per person per year. So not only do we have higher rates of chronic disease and disability, we also have higher rates of poverty among the community members, but we have an impoverished healthcare system through the IHS. And the Bureau of Prisons no longer shares their data because they didn't like the comparisons, but it's been a longstanding issue. There's more money spent per year for the healthcare of federal prisoners than there is on American Indian patients through the Indian Health Service. So yeah, if you wanted better healthcare, you could go to federal prison as opposed to using IHS, and that's just a shame. It's what a social justice and civil rights crime when we see these types of circumstances. And for American Indians, we have a treaty right to healthcare. And basically the tribes exchange land and natural resources for various social services, including housing, education, and healthcare. So that's why we have a BIA, a Bureau of Indian Affairs. That's why we have an IHS, an Indian Health Service. So the IHS is not free healthcare. We exchanged a lot for these services. So I look at IHS as being the largest prepaid health plan in history. And I heard one of the tribal leaders in Arizona say it best. He said, if you want to get rid of the Indian Health Service, that's fine. Just give us our land back. But don't think that'll happen anytime soon, but it's true.
And that's a great point for advocacy, because we need our non-Indian brothers and sisters, our allies, particularly in the medical field. When you are advocating for particular medical services, always mention that, can we please fund Indian Health Service equal to our federal prisons so that Indian people can double health care? And that's all we want right now. We are not even asking for equal health care through Medicaid or veterans or Medicare. We just want to be equal to our prisoners. So that would double Indian healthcare right there, and really address a lot of our disabilities. And then someday, maybe we'll be equal to our fellow American citizens someday. But right now, that first step is to be equal to federal prison.